I'm very happy to be here and to be participating in this session about what I feel is a very important topic. I'm just going to briefly introduce our research program at the British Columbia Centre for Excellence in HIV and AIDS. Our work is really based on the long-term follow-up of 4 cohort studies involving people who inject drugs, living with HIV, as well as street-involved drug-using youth. And we use this cohort infrastructure as a platform for other research activities, including clinical trials and intervention studies, basic science and laboratory research. We also do ethnographic and social science work, but we also have a long history of doing community-based research in our community, and another related important part of that is doing policy research and what we call knowledge transfer. This is a definition by a group of community-based research by some Canadian authors, where they say, community-based research may incorporate either full action, varying degrees of empowerment, or at the other extreme, nothing more than the permission of an involved community regarding a particular research initiative. So very broad, from very complete involvement to more consultation and participation. So what has our work involved? It has really different types of community-based research, including getting community input regarding our more conventional projects, such as our cohort research. We also have on many occasions pursued research at the request of community members who have come to us with an issue or a concern that they'd like us to study. We've also undertaken a number of studies where people who use drugs themselves are actually involved in the research process, help us collect data and design research. We have also undertaken research to support and evaluate a variety of community initiatives and projects, including many peer-driven interventions led by drug users. So let me provide you with some examples of these different ways in which we work with the drug user community. So a major concern in our community, like in many, is the emphasis that was placed on drug law enforcement in the drug scene in Vancouver, including outside of health service points. We have in Vancouver a very large active drug user organization called VANDU, or the Vancouver Area Network of Drug Users, and they are very politically active. Here you can see them delivering a coffin to the mayor of Vancouver in the late 90s in protest because of a lack of action on harm reduction. So in response to the ongoing concerns around police crackdowns in Vancouver, we decided to evaluate these crackdowns. And essentially what we showed is that although the police were successful in moving drug users off the streets, really all they did was displace the drug scene to a neighboring area. And what this shows you is the proportion of used syringes that were discarded before and after the crackdown. And as you can see, while the number of syringes on city streets in the drug scene decreased, in the areas outside the downtown core, it increased. So we were able to convince policymakers that while this crackdown was improving things in the drug scene, it was actually having a negative effect in the outlying areas, and the crackdowns eventually stopped. We also conducted some qualitative research that showed that the crackdowns were prompting people to inject in a very hurried way, that the police crackdown was encouraging syringe sharing, and it was also interrupting their access to health services. We also evaluated the impact of the police crackdown on the syringe distribution numbers from a peer-led syringe distribution program, and this is a before and after analysis. And as you can see, after the police crackdown started, the number of syringes that were being distributed declined quite dramatically. As I mentioned earlier, we have also in many ways used our research to support, generate, and evaluate various community initiatives. In Vancouver, about 1/3 of people who inject drugs say that they need help injecting. They actually need manual assistance with injecting. Usually, if you ask people, they'll say that about 1/3 will say that, yes, I needed help injecting in the last 6 months. And in our setting, with the various programs we have, this is now the strongest predictor of HIV incidence. And that's what this Kaplan-Meier curve is showing you, is the impact of requiring help injecting on the probability of remaining HIV negative. And as you can see, it's quite a problem. So this was also a concern of the local drug user community, so we generated this research in part to help support their initiative, which was the Injecting Support Team. And these people went through first aid training and safer injecting education training, and did outreach in natural settings to find people who needed help with injecting, to provide them with education. And in extreme cases, when people couldn't inject themselves, these people would actually inject them in the safest manner possible while adhering to universal precautions. So we also help them develop a whole variety of campaign materials, such as these educational pamphlets, etc. And they did a series of workshops and educational events for the local drug user community, which then we help support, again, by evaluating and demonstrating the real benefit that this was having on the local community. As one participant said, the Injecting Support Team really represents a unique drug user-led response to the gaps in local harm reduction efforts, including the barriers at the local supervised injecting facility, because assisting someone else with injecting is actually not allowed at the facility. We also have evaluated the Vandu needle exchange services, which came under a lot of scrutiny from the police, as well as their work in providing syringe exchange through outreach. And through these publications, we were actually able to demonstrate that compared to conventional needle exchange services, the drug user-led needle exchange was actually reaching the highest risk members in our studies, those people who possessed all the markers for heightened risk for HIV infection and overdose, and in that way they were really filling a gap in local service delivery. So what about research that includes the participation of people who inject drugs? I'm sure many of you are aware that Thailand has had a really horrific history of extreme violence and human rights violations against people who inject drugs. In 2003, it was estimated that in 3 months alone, several thousand people were executed for suspected drug use. And we, in 2004, helped write a grant to the Global Fund, which ended up bringing the first ever dedicated harm reduction funding to the country for people who inject drugs, and led to the development of several drop-in centers. One of those is the Mit Sampan Harm Reduction Center in Bangkok, which is a peer-run drop-in center where they provide harm reduction and peer support, but also they advocate for the human rights of drug users, including access to comprehensive prevention, care, and treatment. But what happened was towards the end of the Global Fund project, they were faced with losing their funding. The Global Fund funding was about to end. They wanted to continue. And so we decided to do some community-based research with them as a way to try and enhance the program. And so we went to Bangkok, we met with the local drug users, and they said that they really had 3 concerns that they wanted us to address through research. Really how the drug war was being misrepresented as a success when it was actually a failure, the lack of health care programs for drug users, but also they felt that they needed to increase outreach and recruitment to drug users to their drop-in center. So we developed this community-based research project, which was a collaboration with our center as well as the Thai AIDS Treatment Action Group and Chulalongkorn University. For this, we trained 31 former and active drug users to work as peer researchers who were involved in all stages of the project. They helped design the research questions and the surveys. They conducted outreach and also administered the questionnaires with some supervision and support. So what did we find? Well, we found that not only was the research helpful in identifying an issue, it actually increased the number of people who started coming to their drop-in center. When we first did our first wave of recruitment, we found that only 29% of the people we recruited had ever even been to this center. And when we looked over time, there was a continuous increase in attendance at the center after the research had begun. And in this way, we were able to actually help enhance the activities, bringing over 300 new people to the center in a matter of 2 or 3 months. We also responded to their concern around a lack of access to health care by demonstrating the very severe problem of difficulty accessing sterile syringes. We found that 30% of our participants had reported syringe sharing in the last 6 months, and those who reported difficulty accessing syringes were 2 times more likely to report sharing syringes. The reasons for having that difficulty were that they were too far from syringe outlets, that pharmacies were often closed, and sometimes they were refused sterile syringes at pharmacy. But we also engaged the membership in research and dissemination and sharing through the development of plain language summaries like this. So we would write the results of our research in plain language in a short format so it could be shared more broadly. And we would go back and report our results back to the community. And also, when we presented our work, we often did it with a member of the community who co-presented. And this also helped us work with the community to develop media attention to the work that we were doing. So what about this idea of knowledge transfer? Well, I think it's something, given the continued stigma and discrimination against people who use drugs, we really have to do more than just simply publish papers in journal. We have to engage in knowledge transfer, and even if sometimes that means we have to get our hands dirty. At our program in Vancouver, we try and do knowledge translation, or what we call KT, through various methods. Again, creating plain language reports and policy briefs, using networking in the media and publishing newsletters. We try and use as many strategies as we can. So on our website, we list all our publications, and there you will notice that there's 2 hyperlinks. One is to the abstract on Medline for scientists, but then beside it is a plain language summary for the general public. So if you're a scientist, you can read the more complex research summary, or if you're a member of the public or a member of the drug user community, you can turn to the summary. And we did this in the case of the supervised injecting site. We created 1-page documents that summarized all the results. And we created a plain language report which included some of the qualitative data we collected so that the words of drug users were also represented. You're probably wondering who this person is. This is the part where I talk about getting your hands dirty. This is Margaret Wente. She is a very prominent Canadian journalist who has a very large readership. And but I tend to think of her as somebody else. Why? Well, because she says things like this. We waste millions of dollars on prevention and harm reduction methods that are not evidence-based and probably don't work. The point is, these groups are not held accountable for the results they get and the public money they spend. Obviously, this is a completely absurd statement, but as scientists in the community, I feel an obligation to address these kinds of untrue statements by people in the media. So we took this individual before the press council, and there the council ended up siding with us and said that this journalist actually was wrong in how they represented the HIV and harm reduction community, and they were required to issue a retraction and a correction. Another key activity of ours has been to collaborate and support legal and human rights organizations. You've all heard about Vancouver's supervised injecting site and the fact that the federal government tried to close it, but we worked with local drug users and lawyers to help develop the evidence to support this case. We provided expert witness testimony during the court cases, and eventually, as you know, it was successful, and the injection site remains open to this day. But I guess some of you are really wondering, you know, is this really the role of scientists? Should we advocate, or should we just remain neutral on all matters? And I personally believe we should. I think we have an obligation to do that, and I like this quote from the Union of Concerned Scientists, who say, "Scientists and engineers have a right, indeed an obligation, to enter the political debate when the nation's leaders systematically ignore scientific evidence and analysis, put ideological interests ahead of scientific truths, suppress valid scientific evidence, and harass and threaten scientists for speaking honestly about their research." And this has happened to us in Vancouver, just like it has to scientists in the US who have studied climate change. In Vancouver, we've been attacked by some of the nation's leaders for our work on Vancouver's injecting site. But again, through working with the legal community, we were able to win in the end. We've also engaged in and supported collective advocacy in our community. Many of you may recall the Vienna Declaration, which our group developed, where we made a call for drug policy based on evidence, not ideology, and this was endorsed by over 20,000 individuals. And in Vancouver, in Canada, we also created the Coalition of Concerned Scientists, who wrote a letter to all the leaders of all the major parties in Canada and asked them to stop politicizing and misrepresenting science in a variety of areas. And we were able to garner considerable media attention and make this an election issue. So how can we conduct more ethical and respectful research? I think we can do that by engaging directly with the affected community and being responsive to their concerns and undertaking research that helps supports their interests. At the same time, I think we have to maintain a commitment to scientific rigor and peer review. And also being active in knowledge translation, making sure that we're communicating our results not just to other scientists, but to the community at large, and also taking the time to respond to inaccurate media reporting. As I mentioned, a really key part of our work in sustaining effective evidence-based interventions has been collaborating with legal and human rights organizations to make sure that programs that are effective are preserved. And in doing so, we really have to move beyond these conventional mechanisms of dissemination and discourse. It's difficult because the academic system does not reward scientists for doing many of these things, but if we actually want our research to make a difference, I think this is something we need to do. We need to embrace the dual role of scientist and citizen and engage in this type of collective advocacy. If you'd like further information about our program, you can find it on our website. And this is our address here. And I would just like to close by acknowledging the many people who use drugs, who participate in our research, and who collaborate with us in our efforts to ensure access to evidence-based prevention, care, and treatment. Thank you.